It's 7 o'clock, so let's go ahead and get started. We have two great talks by our own faculty today. To start, we're going to have Dr. Jacobs, who everyone knows is a professor and chief of the division of vascular surgery, and he's the Michael E. Dunway Professor of Surgery in Vascular Surgery. He started his education career at the University of Nebraska, and then he was, I guess, a purebred because he went to undergraduate medical school, did his residency there. And then he left Nebraska to go to do his vascular surgery fellowship at the Medical College of Wisconsin. And then from there, he went to St. Louis University and spent many years there from 1994 all the way to 2018, and rose up through the academic ranks there eventually to become the chair of surgery. And then he was recruited here in 2018 to become the chief of the division of vascular surgery and really build a great program. He's the medical director of the comprehensive aortic program here, and he's the program director of the vascular surgery fellowship. He has 73 published manuscripts, 6 book chapters, and has given over 190 invited lectures and presentations. And so this morning, he's going to talk to us about atherectomy. Dr. Jacobs.
I just have to, somehow in that CV, I think you got it, has me the program director, but that guy's sitting right there. All the problems go to him, Dr. Malgore. So I'm going to talk today about atherectomy. We had a grand rounds from Caitlin Hicks, who had a spin on atherectomy. We'll come up and deal with sort of that controversial aspect of atherectomy. But I'll give you a little broader view today. And for that, I'll start with, I have no conflicts. No, it's not moving. I'll just go, okay, it'll go here on this. Okay. Okay. So atherectomy's been around a while. John Simpson, who is a cardiologist in California, has been credited to some extent to development of atherectomy. He's not the only one, but in this country sort of has been given credit, and he came up with this idea. I think he said in 1984, 1987, they had developed some catheters. And this is a picture from, I think, an article that's 1990. And you can see here the cutting aspect here where there's this little slot and there's a curved, cupped, sharp blade that cuts in here. This is another diagrammatic thing showing this aperture. They blow a balloon up and it poses it to the wall. And then you slide this cutting blade along and shave some plaque off and pack it in the tip. This is actually a coronary division version of this, which was made around the same time. I actually had the experience to use this device in 1991. We did 2 cases with it in my 4th year rotation on vascular at the University of Nebraska with a very forward-thinking private practice vascular surgeon. We did 4 atherectomy cases, 2 with another device. It was very educational. They were very scary and didn't work. At least maybe the learning curve was there, but also the lack of sort of bailout things that we have today, like stents. Interestingly, Dr. Simpson used this. This is a Cope pleural biopsy needle. I don't know if anybody used this, but he credits this tool as his inspiration for thinking about how he could have a tube go in and grab a piece of plaque. I don't know, it makes a nice story, but it does look sort of like the aperture of his atherectomy device. So this is the modern version of the Simpson atherectomy. It's evolved a lot in the last 30 years. This is a directional side cutting, and this shows the device. This is 6 French, and it's got a little cable that angles it, puts the cutting blade down onto the plaque, And this thing spins at several thousand RPMs, and it shaves plaque, and it just push forward, and it curls this ribbon of plaque into the nose cone, and you slide the blade forward and pack it in there. Do this several times, have to take it out and empty it. It does lose a little bit every now and then, long, complex disease. I think that the fact that you think you get everything into the nose cone is a little wishful thinking. And so embolic protection is a key part of this, I think, for anything longer than 10 or 15 centimeters for sure. But there are other types of atherectomy, and there are other types of directional atherectomy too. But the other one that I think sort of speaks well to another technique is the rotational excisional and aspiration atherectomy. So this is one that actually has blades that cut. This is a device from the previous one is from Medtronic currently, and this is from Boston Scientific. It has a set of blades in the front. This spins several thousand RPMs. And these blades at the back are on hinges so that if you rotate in the clockwise fashion, they are down. And so the diameter of cut is the size of this front blade. But if you reverse the direction, these blades sort of flip out and lock, and then they increase the diameter with which you can take plaque off to be more aggressive, typically a pass with blades down and a pass with blades up. And also there's this high aspiration rate protection that's to remove all this debris, which is pretty effective. Somewhere in the high 90% of these cases have no embolic complications. But it can be used with embolic protection. The third one that's been around a long time, and this is one that I had a lot of experience with in my practice at St. Louis starting about 20 years ago. And this was the excimer laser. It was made by Spectranetics, which is a Colorado company down in the Springs. And it used and thermomechanical, meaning that as you heat, but also you heat up water and vapor, and that boiling of the vapor can be disruptive of plaque. It really works well with fibrous disease. It doesn't really work with calcified disease that well. And it does generate a fair amount of emboli, or generates material that can embolize when you balloon it afterwards because you've kind of roughed it up. And this just shows the end of the laser fiber, the new ones that are eccentric, so you can rotate them and theoretically get a little bit bigger range. One of the new devices that's out in the last few years, and again, this is an evolving technology continually, or there's something new all the time, is an Arterial laser. And it's interesting that a little difference in the wavelength and a little difference in the pulse that's used can make a very big difference in how the energy interacts with tissue. But it's more effective with calcium. And it also has a catheter, because it's more potent, it can get good ablation with a ring, but you also have an aspiration port in the middle of the larger catheters. The smaller ones do not have aspiration. The main limitation of this, actually, interestingly, and we've been using this for a couple of years, is the sharp edge of this. This doesn't track well. They just came out with sort of rounded tip catheter tips, which is hopefully going to make a difference. So again, evolving, devices just continue. This is the latest sort of iteration of peripheral vascular tools, and this is a rotational atherectomy. This actually started in the coronaries with the rotablator, which was a pretty revolutionary tool but that was just a front cutting burr. In this instance, for peripheral, the burr is in the back from the end of its wire, and it has a elliptical shape. It's offset so that the speed of this can be set at different speeds from 10, 20, 30,000. And the larger diameter, as that elliptical thing starts to go in a more orbital fashion, can make a larger ablation path. Problem with this is that you're grinding up sand, debris, and that has to embolize somewhere. So the main limitation of this device is distal embolization. This actually has a pretty good role, and a growing one in coronary, which is a scary thing. They talk about all the drugs they have to vasodilate and flush this stuff through the capillaries. To me, I think that's sort of wishful thinking. I think this device does some permanent damage to runoff, but it is an amazing tool for calcified lesions. So let's talk a little bit about data, and I'm just going to give what I think are the most tried and true studies here. But this is from directional atherectomy. That's that directional catheter that I showed at the beginning with the cutting blade. And this study was done, really executed back in the late, about 2008, I think. And so it's been around. I was actually chair of the clinical events committee for this. It took years to get this study done. But it was, I think, well done. It actually has some decent data. And it shows that a 75% patency at 1 month. That means by looking at duplex, nobody had a velocity ratio of greater than 2.4, which would be around 50 to 60% narrowing. That's a pretty hard criteria to meet to say that, well, you just have a little bit of stenosis. This is not the typical, well, they didn't need another procedure. That's kind of the mantra in cardiology, to have a failure being that, well, they had to have another procedure to treat it. This is actually looking at an imaging tool, and this is a pretty sensitive way to look at stenosis. And then they separated out a long subset, followed them as well, 232 patients, which this is more real world sort of disease of about 15 centimeters, and a 65% patency, meaning they had nobody that really even had any stenosis by duplex at a year, except, well, had 65% who didn't and about a third that did. So not bad for a peripheral arterial. The other thing that was a very definitive trial to say what's a role for atherectomy, and that was the Excite trial using laser to look at in-stent restenosis. In-stent restenosis in an femoral popliteal segment is a really challenging and unfortunately fairly common problem from the past when we had stents that were not really functional like some of them are today. And so treating these was a common in my practice. I was actually in this trial as a local PI at SLU and enrolled a bunch of patients. So this was ended early at 6 months. This was planned to be at least a 12-month trial follow-up. They got 6 months follow-up and showed this dramatic difference of lasering and balloon versus balloon alone of 73 versus 51% in freedom from reintervention. This is that term I was using that doesn't talk about stenosis. It's just, did they get away with having no procedures or not? But again, this was I think a clear role for this device and maybe other atherectomy devices for in-stent. The last one I'll talk about, I got one, I'll talk about the rotational atherectomy in a minute, but Jetstream is got a study that really shows similar stuff. 82% freedom from reintervention at 12 months. Again, not quite the restenotic criteria that we were looking at, but not bad clinical results. And they've done an in-stent restenosis study, which showed, interestingly, with this thing spinning around in there, didn't grab a hold of stents or rip them out, and was safe and effective. This is the only one. There's about 6 trials from the CSI orbital atherectomy that have been published. And this shows, I think, they're the last and the largest critical limb ischemia trial, showing really pretty amazing results, almost too good of results. That, and we'll come to that too, that show that in these Kaplan-Meier curves that the reintervention rate, even for Rutherford 6, was amazingly good. These patients, I don't know, we don't see these patients that if they have Rutherford 6, they've got lots of problems. That's gangrene. So this is a brief sort of touching on what there's about 100 papers out there on atherectomy. And I found this, it's interesting, it has a title very similar to one that we did recently. And I see Dr. Malgore studying this slide, but a critical view of peripheral atherectomy. And this was in 2014. It's from Cardiology Journal. And I'll just, they tried to do a sort of systematic review, but they really couldn't find anything that was really meaningful. All they had were single arm registries or case series. These are the studies that they reviewed, and all of these are industry sponsored studies. And I've showed you some of those. So the conclusion was really this data doesn't support the use of atherectomy alone in PAD. Now, I think the word alone is sort of out of place here. And I think that it's a little bit strong language to say that it doesn't have a use. But this was, 8 years ago that people were saying, well, what's the use of atherectomy? And at that time in my practice, I was using very little atherectomy other than for in-stent restenosis. But we'll talk about maybe what would be appropriate uses of it. And again, I think it because of complications, embolization, recurrent stenosis, and cost and time. So our group, led by Ryan Gupta, Sam Asiata, and also Emily and Rafa Malgore, I had a small role in this, did a systematic review. And this review ended up coming up with 24 studies that met the inclusion in about 1,500 patients, about 500 of those treated with, compared to no atherectomy. And then, 500 patients compared to those outcomes who had no atherectomy. In a reasonable distribution, although again, pretty low level disease, that these are claudicants, so about 75% of them. And only a quarter of them really had what we think is critical limb ischemia. And there were a lot of adjunctive techniques. And there was probably a variation in techniques of how these devices were applied. So it's a little bit dirty. The data varies a lot, but you try to sort that out. But looking at overall technical success, distal embolization, vessel perforation, and dissection seem to be reasonable numbers. I mean, maybe the technical success being a little bit low. I don't know exactly what criteria each study was for that, but perforation and dissection, distal embolization rates are about what they are. And the follow-up, though, showed that atherectomy was 72.6% versus non-atherectomy of, 72.6 and 74.6. So really no difference. Maybe you could say there's, even favoring not treating these with atherectomy. The problem is there's no real stratification of the extent of disease, the level of occlusions, calcification, where they're being, what part of the femoral popliteal artery are being done. So I don't know that you can make a lot of conclusion based out of this, other than the fact that there doesn't seem to be a lot of benefit, let's see, to differentiate these. So as you may recall, Caitlin Hicks was here from Hopkins a couple months ago and gave a really nice talk about utilization of atherectomy. And it has increased. There's no doubt about that. And this is another study, not hers, looking at VQI, Vascular Quality Initiative, which is a very good database of vascular intervention. It was utilized in 8.5% of the cases in 2010 and about 20% in 2019. So that's a 217% increase overall in atherectomy. But if you look at in the Vascular Quality Initiative, at least, I think this is a little bit overstated, but it's a huge increase in the number of these that were done in office-based settings. And part of this is a time frame during which office-based labs have been developed. This is an outpatient setting, of one of which we have across the street. And they have put data into VQI. I think that is not typical from a lot. So I think this is where an office-based setting maybe is distorted a little bit, that the volume that was in this study to initiate the, early in 2010 was essentially zero. So any number is going to go up dramatically, but clearly increased. And just to put it all into perspective, there's about $250 million paid to physicians for index femoral popliteal. That's just one level of, vascular disease in 2019. And it's been proposed that the high reimbursement that's offered in the outpatient setting is one reason why this has increased. Well, if you look at the utilization rates of atherectomy, I think is also interesting. This is another study looking at, who is using it and also over a time frame. So in 2011, 43% of the atherectomies were being done by cardiology, radiology only 19%, and vascular surgery 28%. This is in all settings. And you look 8 years later, and cardiology's gone up by about 25% or so. Radiology is almost tripled, and vascular surgery's gone up by about 50%, or a little more than, a little under 50%, or 100%, I'm sorry. So this is definitely a big change, but it's also a differentiation early on in the distribution, which has become a little bit more equivalent for specialty participation. This is the data from Hopkins, and again, looking at Medicare claims review. So that obviously has very little clinical information. It has a lot of other administrative information. And it shows that for first-time femoral pop tail interventions in 2019, 60% nearly used atherectomy. And that's a change in practice over the last 7 or 8 years, clearly. And the reintervention rate on a follow-up through the Medicare claims database was pretty high, 40% in all patients. And higher, those with atherectomy nearly 50%, and those with non-atherectomy procedures about 30%. So you look at this, and this is pretty damning in the numbers here. However, again, there's no stratification of disease. So atherectomy is, maybe utilized in a more extensive disease where you don't have complex lesions where you think you can just treat it with a balloon. That's not known. We don't know what the disease distribution is in this, but it clearly shows here that use has changed. It's very high, and there seems to be a high rate of reintervention in those patients that have had it. Here's a graphic of that, and this is interesting too because it shows that overall volume has increased in treatment of these patients. And again, a large number of these are claudicants. But if you look at atherectomy alone, has clearly increased a lot. Atherectomy with stenting at the top, being the sort of most complex disease treatment, has increased, and stenting alone has decreased. And a lot, say 10 years ago, people would have said, well, that's a great thing because stents just don't last. We need ways to try to not have stents in there because they cause trouble. And I think that's some of the motivation for utilizing atherectomy. Let's go back to the specialty-specific reintervention rates. This data is interesting to me that in this data set, they can look at, who's doing the reinterventions. So if you look at cardiologists versus vascular surgeons, the hazard for a reintervention ratio is 1.22. And for radiologists versus vascular surgeons, that ratio is 1.55. So maybe that speaks that vascular surgeons are being more effective in their treatment, that we're not having the reintervention rate, but we're still using atherectomy to a fairly common extent in this data set, to about 50%. So maybe it's a form of practice. It was not associated with location of practice, the reintervention rate, but the way it's practiced. So I'll leave that as a controversial point. And I could say I'm done and have you just read this. But this is a paper that Dr. Malgore and Dr. Neves put together, along with help from Emily and Mahmoud, who have really, I think, they've summarized a lot of the things I'm going to say in the last few slides. And, how do we really approach some of this data? So first of all, what are the drivers for increased atherectomy utilization? Well, one is, I think, I mentioned avoiding stenting. That's been the mantra for a long time. That's been vascular surgeons talking about that more than any other specialty group because we have an option to say bypass. I actually think stents placed in the right way with the right technology actually have very good results. But it's also technique dependent. So patients know this, they hear stents are bad, they want to avoid them. That could be a driver for someone trying to use a technology like atherectomy to reduce the need to put a stent in. And we are doing more complex lesions. So as you do more complex lesions, you need more tools. And if you're trying to avoid stents, other tools include a lot of things, one maybe being atherectomy. But things I listed here in this third bullet, drug-coated balloons, cutting and scoring balloons, lithoplasty, which is shockwave, for calcified lesions. These are things that have really changed the practice of vascular surgery over the last several years. And interestingly, if you're working in an outpatient lab, which a lot of these people are, particularly some of the other specialties, do not have reimbursement for these other technologies. You get reimbursed for atherectomy, but you don't get reimbursed for these other technologies. So if you've got a complex lesion, you're limited to atherectomy with stenting to get paid to do complex lesions. And that's a topic that's never really been brought up, I think, as a driver for why this is done. And I can speak from personal experience that when we have someone, if you're in the lab and you've got a problem, you don't have things like the latest Serenator balloon or whatever, because those are $1,500 and there's no else escalation in what you get paid for that. So the hospital takes the hit, though. That's the other thing. If we're doing them in the hospital and using these technologies, they are also not reimbursed. And so if you're tied in tight with your financial people at the hospital, they're going to come down on you for using devices that are not reimbursed if you use a lot of them, and atherectomy is reimbursed. So I think in the last decade, that's been a small part, at least, of some of the increased utilization. So I'll finish by saying I think the most important thing clearly is the increase because of motivation to make money in the office-based lab. Where is it appropriate? I think atherectomy has a role in focal lesions where you don't want to stent, the common femoral, the ostia of the SFA or the profunda, short or moderate, femoral popliteal lesions. It doesn't work stenting in tibial lesions and in stent stenosis. And for best practice, I think we should keep to try to limit atherectomy because of its difficulties with embolization and recurrent stenosis. And that's not a new practice for me. I've known this for over a decade. Reimbursement should be moderated, I think, and make it more even, and they should pay for things that don't currently get reimbursed, such as specialty balloons and other things. And that the outcome reporting of outpatient labs is a key. I think the oversight that would come with reporting your outcomes in an outpatient lab would be key to really making better care for all our vascular surgeons or vascular patients. So with that.
Anyone have a burning question for Dr. Jacobs? If I don't see anybody raise a hand, I'll ask a question. So it seems to me like every time there's a new technology that's introduced, you see a loosening of the indications for a procedure. So I remember back when laparoscopic cholecystectomy was first introduced, the year after it really took off, the number of cholecystectomies that were done in the United States was like twice as high as it had been the previous 5 years on average. So how do you really deal with the fact that sometimes these devices are being used for things that never would have an intervention, only for the fact that this is minimally invasive?
Well, that's a good question. That goes back to any, minimally invasive intervention. I think that the pull of this is risk benefit, maybe is part of it, that there's less risk. I think also it's patient desire. We're talking about 75% or so of some of these studies here talking claudication, and is claudication treated medically? I think that really hurts a lot of people that really do see a significant change in their life. I don't know how that relates to gallbladder disease too. If they've got some pain and it's not killing them, we wouldn't have operated on them, but now we have a tool, we'll just take that pain away from them. That's medicine. I think we get safer to some extent, minimally invasive things, then it's going to get applied wider. I don't know that that's unique to, this isn't unique to peripheral vascular, but I don't know how you solve that.
Yeah. Dr. Cleveland.
Hey, Don, that was a great review of a very broad topic. Question I have for you is the registry reporting and the reintervention used as a endpoint, particularly in the cardiovascular world. A lot of these things are staged, where they're going to come to the lab this time and get a certain territory worked on, and then they come back a month later. So in the registry world, will the vascular surgery registry try to differentiate? Because I know Medicare doesn't do that. And that might be one of the things that is leading to this, kind of perception, at least, that there's a lot more uptake and reinterventions. Will there be for a planned staged, you've got a SFA lesion, one leg, you can go do the other leg and a month later. And, the reasons to do that, both financially as well as patient related. Well, will the registries account for that? Because I think that is an important thing for why we've gotten away from that specific endpoint, at least in the cardiovascular world.
Well, I think we do staging a lot, and what we do here with complex disease, aortas being the greatest example of that. Peripheral vascular, we really don't do a lot of staging. In the right and left leg, those are separate. So those would not be included in a follow-up intervention if they were treating the other leg. That data is clean in that regard. But, the registries still have lots of other faults. And so reintervention, is that really the thing? If you look at that one trial, the definitive LE trial, where they actually showed very good ultrasound, adjudicated core lab review of those, that's real data. Knowing whether somebody comes back or some of these industry sponsored things are that 35% of patients who don't follow up, and that just destroys your data. So I really don't think that the registry data is what it should be, but maybe not because of staging. Yeah.
Thanks very much.
Thanks.
All right, let's